So today we'll talk about enteric fever, also known as typhoid fever. It is caused by a bacterium known as Salmonella typhi. It is endemic in Southeast Asia mostly, countries like Bangladesh, Pakistan and India. In this slide, we'll talk briefly about the clinical features, the diagnosis and the management of the patient. So this is an acute infection of the intestinal lymphoid tissue, gallbladder, and the reticuloendothelial system. It is an acute illness associated with fever. There is another bacteria known as Salmonella typhi. It causes. So typhoid fever is actually an acute generalized infection of the intestinal lymphoid tissue, gallbladder, and the reticuloendothelial system. It causes an acute illness associated with fever. There is another bacterium known as Salmonella typhi, which causes typhoid-like illness, but the illness is less severe. Typhoid is actually transmitted by fecal-oral route, so it gets deposited on the food or in the water, and through this it gets transmitted between the humans. Human is the main reservoir and carrier of typhoid fever. Here you can see the incidence of typhoid. You can see countries as you can see, most of the cases are in the Southeast Asian countries, the Sub-Saharan African countries, and countries like Mexico, Ecuador, Peru, and Chile. We do get around 400 cases annually in USA alone. They are rare, but they do happen. As you can see, there is a close link between typhoid and in underdeveloped countries. There are more cases and they are at higher risk because it is a foodborne illness, and the sanitation and the living quality in these countries are generally not very good. So here I have tried to divide the cases of typhoid fever in three broad categories. A patient with fever of 38 degrees Celsius and above that has lasted for at least 3 days and the laboratory confirms a positive culture of Salmonella typhi. This is a confirmed case. A probable case would be a patient with a fever of 38 degrees Celsius and above that has lasted for at least 3 days with a positive viral test, but without the isolation of Salmonella typhi in laboratory culture. A chronic carrier would be someone who shows Salmonella typhi bacteria in his stool or urine for longer than 1 year after his acute episode of typhoid fever. A short-term carrier can also exist, but they are not that important as chronic carriers. There are some asymptomatic patients which might not show any symptoms, but they might be carriers of typhoid fever. So what are the symptoms of typhoid fever? The incubation period of typhoid fever is usually between 1 to 2 weeks, and it can be longer. The occurrence of typhoid fever is sudden. The symptoms are generally non-specific. There can be multiple differential diagnoses of a patient presenting with typhoid fever. So if left untreated, this can lead to death of the patient. So here I have tried to divide the clinical features as they happen over time. So in the first week, there will be slow rising fever, step-ladder fashion for 4 to 5 days. Here, step-ladder means that when we draw a graph or a temperature chart, it shows a step-ladder pattern. That means the fever doesn't spike. It gradually increases between 4 to 5 days. And the patient will complain of abdominal pain and myalgia, malaise, headache, constipation, and relative bradycardia. So by the end of first week, some patients might present with rose spots. They are reddish spots present on the upper abdomen and on the back of the patients. Actually, rose spots are not very common. They happen to patients. They happen to only 40% of the patients presented with typhoid who are presenting with typhoid fever. They may be cough. They might have splenomegaly, abdominal distension with tenderness, and diarrhea. So by the second week, the signs and symptoms of the first week will progress, and by the end of second week, the patient will deteriorate if left untreated, he might develop delirium and other complications, which might lead to coma and death. By the 3rd week, the patient will become more febrile, toxic, anorexic, and there will be significant weight loss due to anorexia and a state called typhoid state. There is high risk of hemorrhage and perforation of the GI tract, which may cause death. By 4th week, if the patient survives the 4th week, the symptoms start to improve over a few days. Intestinal and neurological complications may still occur in surviving untreated individuals. Weight loss and debilitating weakness could last months. Some survivors become asymptomatic Salmonella typhi carriers and have the potential to transmit the bacteria indefinitely. Here you can see the most common symptoms: chills, sweating, headache, abdominal pain, staphylococcus fever, diarrhea or constipation. So here we comes to the diagnosis and investigations that would determine if the patient have or have not Salmonella typhi infection. These are the definitive tests, so it includes blood culture, vital test, urine and stool culture, marrow culture, 90% sensitive if done after 5 days, punch biopsy samples of rose spots. So these are not very sensitive and not usually done in the case of a suspected typhoid fever. Clot culture, again, not usually done commonly. Actually, the diagnosis of typhoid fever is made mostly clinically in endemic areas because this disease is very common there, so they don't do much of these testings, but they do blood culture, urine and stool culture, but all these other things are usually not done. Other non-specific lab studies might show moderate anemia, increased ESR, thrombocytopenia, lymphopenia, slightly elevated PT, PTT, decreased fibrogen level, liver transaminase and bilirubin might increase 2-folds. There would be mild hyponatremia and hypokalemia. So the management is mainly supportive, including antibiotics and antipyretics. Steroids might be used in severe cases. We usually encourage oral feed. Soft diet is preferred. Surgical care might be needed in case of intestinal perforation, which is rare, but it still do happen. Here I would like to mention that antibiotics such as chloramphenicol, penicillin, cotrimoxazole has shown great resistance to antibiotic susceptibility in Southeast Asian countries for typhoid, so they are not generally used. The most commonly used antibiotics are ciprofloxacin, 500 mg BD, ceftriaxone, cefotaxime, again 500 mg BD. Chronic carriers were previously treated for 4 weeks with cipro, but may require alternative agent and duration as guided by the antimicrobial sensitivity testing. Cholecystectomy might be needed, but it's still rare. So here we have come to the end of the slides. I hope that you might have found it helpful, and if you have any suggestions, please comment down below. Thank you so much.